Good evening, everyone, or good morning, or good afternoon, depending on when you're watching this and where you're joining us from. Welcome to our Ask the Doctor session tonight. My name is Shelly Kurian with SkyPass Foundation, and I thank you guys for taking the time to join us today, those of you who are joining us live. I'm excited for you guys to hear from our guest tonight, Dr. Alberto Espay from the University of Cincinnati. We are covering the topic of medications for Parkinson's disease tonight, and Dr. Espay brings with him a wealth of knowledge and experience in this area. He has published over 250 research articles and book chapters, as well as 7 textbooks. He currently serves the International Parkinson and Movement Disorder Society as chair of the Task Force on Technology and as secretary of its Pan-American section, in addition to his many other accomplishments. Dr. Espay, thank you so much for being here. We're honored to have you. We also have with us Dr. Shilpa Chitnis here tonight, no stranger to us. Dr. Chitnis sits on our board of directors here at SkyPass Foundation, and she is a professor of neurology and movement disorder specialist. So with that, Dr. Chitnis, take it away.
So my first question to you is, this is an age-old question that has always been asked. You meet a patient, you diagnose them with Parkinson's disease, and then your decision is, should I treat or should I not treat? And a long time ago when I was in medical school, the paradigm used to be that, go away, you have Parkinson's disease when you're more disabled and can do certain things and come back. And so I want to ask you, what is the current approach?
Well, thank you, Shilpa and Shelley, also for the kind introduction. I first think that is very important to recognize that each individual is very much unique biologically and therefore on a behavioral level. So people are having different types of problems. Now, having said that, when we use the term Parkinson's disease, we use it because even though we acknowledge that there are many different types of Parkinson's, what is common across everyone is the deficiency in dopamine. There are other neurotransmitters that could be affected, but dopamine, when deficient, is very eloquent, and it generates the types of abnormalities that we recognize as being very much classical of those who have what we refer to as Parkinson's disease. Dopamine deficiency is very important to correct, and it is relatively easy to correct. The best way to correct dopamine deficiency is with levodopa. And one of the most important messages to people with Parkinson's is that the strategy to treat Parkinson's with levodopa is no different than the strategy of correcting glucose metabolism with insulin. Diabetics that require insulin are used to the concept that they need to have insulin in a level that will normalize the function. They get to take as much insulin as necessary to control their function. It is no different in Parkinson's. Levodopa is what is produced at a lower rate from levodopa. The production of dopamine is, of course, therefore affected. And all we're doing is elevating the tone of levodopa that's not adequate enough, that's below what is required for normal function. And we're aiming at normal function. So we want to raise the levodopa levels to an extent that would bring out normal function in everyone. So ultimately, levodopa is the most important of all therapies. And we like to start as early as possible in most people. We don't have to in people who have very, very mild symptoms early on, but we don't have a good reason to delay it. There is no long-term benefits that can happen if we delay the initiation of levodopa by months or years. In fact, if people wait too long, then some of the difficulties that appear may be hard to correct over time. So, and then there is a variety of other therapies, but by and large, levodopa is truly the most important of the strategies. And I see one of the questions is about Rytary, and Rytary is just a form of levodopa. So Rytary and Sinemet are in the same category, and of course, we think of both Sinemet standard immediate release carbidopa levodopa as well as Rytary extended release carbidopa levodopa as being in the same spectrum of uh, treatments that are helpful to restore that which isn't manufactured at the levels that warrant normal function.
Thank you. So, but there's still patients that you might say um, that perhaps I, may not treat, or are, would you say your symptoms are very mild? Maybe consider a milder agent such as a monoamine oxidase B inhibitor, such as rasagiline. What do you think about that?
Yes, there is a room for milder agents. The mild B inhibitors are in that category. They are not nearly as effective as levodopa, but in those individuals that have very mild symptoms and would rather not have levodopa at that moment, at the moment of initiation, mild B inhibitors are very rational treatments to consider. There are two, selegiline, which is the older MALB inhibitor, very good, taken twice a day, may have some weight enhancing effects by virtue of what it becomes metabolized into. And then the newer of the two is rasagiline, which is taken once a day, but doesn't quite have the same weight enhancing effect that selegiline conveys. Those are very good options. The class that most people think about as separate from these two that may be of interest to some is dopamine agonists. Those are pramipexole, ropinirole, and rotigotine. The latter is a patch formulation. Rotigotine, pramipexole, and ropinirole are in a class that's in and of themselves very unique. They were very important when they were added onto the armamentarium, but it really is the case that there are some issues with them. We've learned over the years that they tend to be important for certain features, but there are a number of issues with them that perhaps we can discuss later if Dr. Shitness, you wish to.
Yes, absolutely. Thank you. What are your thoughts about the Adagio trial and about rasagiline having any neuroprotective properties, if at all?
Well, oh, let's go from the small picture to the big picture. The small picture is that rasagiline, when it was introduced, had properties known at a molecular level that were very appealing from the standpoint of changes to the machinery that were thought could be neuroprotective, or what we call disease modifying. And therefore, when it was tested in the Adagio trial on a very interesting design called the delayed treatment design, demonstrated that people who had that therapy seemed to progress slower at the 1 milligram dosage, yet those that were treated with the 2 milligrams, so just 1 milligram difference, did not have that benefit. The explanation was that perhaps there were more symptomatic effects. There were more dopaminergic effects in the 2 milligram dose compared to the 1, and therefore we ended up moving away from the concept that Adagio was in fact demonstrating disease modification effects, meaning that it was slowing the disease progression. Now, we as a field have switched back and forth between the development for symptomatic therapies and the development for disease modifying therapies as if they were ends of the spectrum, and they are not. They are completely different animals. Disease modifying therapies, that is, therapies destined or designed to slow down the progression of Parkinson's, will never work with the same paradigm that we use to test therapies that may help symptoms. What I mean is that symptoms are helped across everyone because they tackle the treatments to help the symptoms, common denominators. Dopamine deficiency, a common denominator. Disease-modifying treatments, on the other hand, cannot ever work by addressing common denominators. If there is something that is too common across everyone with Parkinson's, cannot be causal. And the treatments for uh, slowing disease progression must address the cause of the disease, right? And since we know, or we should, that Parkinson's isn't one disease, but many, we cannot ever expect that one disease will ever show to have properties of disease modification. Cannot. The fact that we insist that we could has led to decades of wasted resources on harming people, because all we can accomplish in trials that have this one very fascinating molecule that could cure Parkinson's disease is either nothing or harm. But the possibility of, in fact, slowing disease progression in anyone is literally zero.
Thank you. At what point did we go from thinking about? I remember when I was a fellow, our major goal was to basically use levodopa sparing therapies because we were always worried about motor fluctuations and dyskinesias eventually developing. And I think patients to this day, fear that. At what point did a paradigm shift happen when we stopped worrying about that?
Worrying about the dyskinesia in general as a side effect?
Or worrying about, like, the fact that we don't have to use levodopa sparing therapies early in the course of the
I
disease.
see.
We could use
I,
levodopa.
I think that that time came on when we began to understand that the benefits of the so-called levodopa sparing drugs were in fact uh, outweighed by the many shortcomings. And they were the newer kids in the block, these other drugs that weren't levodopa. There was a lot more money to be made with them, as you can imagine, from different companies that were advocating for its use, for the use of different of these medications. And therefore, levodopa kind of came to be viewed as a bad thing. If you take levodopa, you'll have some problems that are very clear, fluctuations. You will have dyskinesia. Whereas if you take these other new drugs, pramipexole, ropinirole, you will not have those problems. So what happens is that the main goal of trying other agents, that is of sparing people from levodopa, became the idea that if you stay off of levodopa, you will not have motor fluctuations off, particularly off periods, nor dyskinesia. The issue then became that essentially we learn that the reason people with levodopa develop those problems is not that levodopa is bad, it's because levodopa is too good at what it does. It is the only medication that can bring people to an on state. The on state is when people say, ha, I get it, I'm now back to normal or very close to it, right? Off state is the period when that goes away. And as you can imagine, if only levodopa can induce an on, then only levodopa can induce an off, because the off requires the on framework to make sense of what an off means. Well, what happens in clinical trials when they were comparing levodopa to, say, pramipexole or ropinirole, is that the studies would show that levodopa compared to pramipexole was worse because it was leading to more off time compared to pramipexole. So the market of success was the extent to which off was present or not. So when you ask a person with Parkinson's, do you ever experience an off? If the person has 10 years worth of Parkinson's, for instance, and the answer is no, that is not a sign of success. That means that individual has never experienced the joy of on, the state when the medication works the best. And so that could be the individual in levodopa sparing strategies, right? Pramipexole or propionate, a combination of them that would have done reasonably okay, but it would have never been the kind of benefit, the magnitude of improvement that could have led to the type of benefits that we know can only be achieved with levodopa and lev-2 on. And therefore, because levodopa as a molecule is delivered in a very short acting formulation with immediate release carbidopa levodopa, then those benefits tend not to last long enough. That's why when they wear off, then the off state occurs, the reemergence of the symptoms. But the only reason we know that there is an off is because levodopa exists to provide a magnificent magnitude of response unparalleled by any other intervention except two. Apomorphine is equipotent to levodopa, and the brain stimulation, equipotent to levodopa. Those three are the most important, most effective therapies in Parkinson's disease. Nothing else can ever replace them. Particularly, nobody else, no other therapy can surpass what levodopa introduces. And that's why these levodopa sparing strategies of the 90s and early 2000s gave way when we finally recognized that none of the benefits of these other therapies could ever match levodopa, nor any of the side effects of levodopa were related to problems with the molecule, but just simply artifacts of the way in which we are able to replenish the levodopa in the brain.
So it's really important for our patient population to really understand that levodopa is good and not not bad and not the culprit, and certainly does not contribute to disease worsening, because even to this day the myths exist that delaying levodopa is good to prevent these so-called complications of levodopa therapy per se. And you're ahead of me, because I was going to ask you, were there any molecules that you thought were comparable in efficacy to levodopa, and you hit that question as well. Any thoughts about levodopa contributing to worsening of the disease per se? Because there was a point when there was a thought that levodopa could possibly destroy dopaminergic neurons and would worsen disease progression.
Right. Those thoughts that were involved in the late 80s, early 90s, and then it spilled into the internet, and that's why you still run into them, came from laboratory investigations using doses of levodopa that are 10 times those that we used for people. And when you put in a petri dish neurons that make dopamine, and you add to that mix a dose of levodopa that is 10 times that which we use normally, sure, it will kill the neurons, but so is water. If you drink too much water, you're gonna be poisoned with it, right? So it's all about an issue of dosage. The dosages that we used for the treatment of Parkinson's are the ones that can never lead to toxicity. It has never been demonstrated that the doses that we typically use, there is any harm being done to neurons. We're simply replacing that which isn't being manufactured at sufficient rates, period. So any thought that levodopa does harm intrinsically by virtue of what it is, or that the benefits to levodopa are ultimately going to go away, are unfounded. Levodopa continues to work forever. And the only reason that sometimes there is reasons to adjust the dosages upward as we go onward with the disease is because the efficiency with which the brain operates the conversion from levodopa to dopamine is attenuated over time, but mildly so, and it never to the point where the response will go away.
Very good. So just again, coming back to early therapies, I have a couple of questions that I want to ask. So as far as the MAO-B inhibitors are concerned, especially rasagiline, which we use a lot more than salicylic, what do you think about two things? So number one is basically drug interactions with antidepressants, especially the SSRIs. I think our pharmacists still sometimes freak out about that. That's question number one. And then question number two the interaction with foods that basically contain this compound called tyramine, which is found in, like, red wine and blue cheese and cured meats, which are really consumed more by Europeans than by Americans, but still.
Not really. Look at this.
I've
Uh,
cured meats and blue cheese.
so good questions. And in fact, you're correct that pharmacists worry excessively about the interactions, and that interaction is still listed in the pharmacy books between SSRIs and the selegiline and rasagiline. Well, it turns out that the dosages, coming back to the dosage again, used for the treatment of Parkinson's disease will never be sufficient to change the selectivity to the type of receptors that those drugs work under or on, which is the B type receptors of the MAO system, the monoamine oxidase system. If you use too high a dose, that would not be any that we would ever recommend, then that selectivity is lost, and then the tyramine cheese effect can occur, both with the cheese or the wine, for instance, or with the SSRI antidepressants. But provided that you're using the drug at the dosage that's recommended, never has there been a case with selegiline or rasagiline that would be worrisome, either because of the so-called serotonin syndrome, whether it's rigidity, impairment of consciousness, and sometimes fever. So a really bad state is an emergency. That has never been shown to occur in this situation when the dosages are appropriate, nor hypertensive crisis, which is what the tyramine cheese effect would be. So we tell the pharmacists to not worry about the interaction that's theoretical, but never demonstrated in practice.
Okay, so talking about dopamine agonists, I remember when I was in residency in the late 1990s, when these agents came on, they were considered to be wonder drugs because that means you could delay levodopa and
when we thought delay levodopa was very important.
correct
It
at
is
that
not
point, right? This is, yeah, not anymore, but we're talking in the 90s. So what do you think about dopamine agonists today? So the main, if you can highlight the main problems that exist with the use of dopamine agonists, and what, if at all, is the role of dopamine agonist in Parkinson's therapy in 2020?
Good question. So there are, I would think, two major handicaps of dopamine agonists, as well as two potential roles still in 2020 for them. The handicaps are that they can induce excessive daytime sleepiness and impulse control disorders. Excessive daytime sleepiness can be so bad that people fall asleep at the wheel, for instance. I mean, it can be that bad. Now, it's not necessarily that common to get that level of severity, but it is possible, and therefore accidents could happen. Impulse control disorders refer to the types of risk-seeking behaviors that are uncharacteristic in Parkinson's, and those include compulsive shopping, excessive gambling, hypersexuality, compulsive buying, compulsive eating, for instance. So all of those excessive behaviors that are hard to control. That's not typical for anybody with Parkinson's, but under the influence of dopamine agonists, they can occur. And that's why we worry about these two elements. Now, there are a variety of other side effects. Those are the two major ones, but then the rest is cognitive impairment can occur with dopamine agonists. Hallucinations are common with dopamine agonists. Leg swelling is common with dopamine agonists. There is a variety of other effects that when you start kind of putting them all together, they are almost 30, sometimes 40% when you put it all together. So it's a lot of people that would stand to be to have side effects with this, some of which are going to be disabling side effects. What are the potentials therefore? Well, we are not thinking of dopamine agonists as the type of strategy that we would be thinking right off the top for most people. But where they might still be very helpful is in restless leg syndrome symptoms, and RLS, our restless leg type behaviors, are common in Parkinson's, and levodopa isn't as good for this as dopamine agonists are. And that will be one area in which then pramipexole, propinitol, or rotigotine could be very helpful. The other one is mood disorders, particularly depression. Dopamine agonists, in fact, are there's a literature of their use in depression, major depression, not even the depression of Parkinson's, but by people with depression. And studies have been done showing against placebo that dopamine agonists can have an antidepressant effect. So you could argue that this would be a class of medications to consider among those who have depression. Now, you have to balance that against the other side effects that I just mentioned. So you probably are better off trying other antidepressants and maybe considering dopamine agonists a little later down the line if other antidepressants have not really worked. But for other symptoms of Parkinson's, rigidity, slowness, difficulty walking, tremor, I don't think that that's a role. I remember going back to the time you were talking about, Shilpa, when pramipexole was being sold as a great anti-tremor agent for Parkinson's. That if patients have tremor, pramipexole is the drug that we should use. And I think that we learned the hard way that that really wasn't necessarily the best strategy for it. That tremor happens to be, among all the symptoms of Parkinson's, the one with a higher threshold for benefits with levodopa. So levodopa helps with rigidity, that's the stiffness, the slowness, but it requires a higher dose to help with the tremor. So the tremor is not that it won't respond to levodopa, it's that it really requires usually higher doses for it to melt away.
It's interesting how you are reading my brain as we are going along, and you're asking. I was going to ask you the same question about antidepressants and RLS. There is a use, but unfortunately, once a person develops impulse control disorders, then trying to back off these medications, um, especially, can also result in a dopamine agonist withdrawal syndrome, as you know, which is really just really really hard to basically manage. Have you used valproic acid for treatment of either a dopamine dysregulation syndrome or an impulse control disorder?
I have not.
And
You?
there's really no this, I think, one paper from Michael Okun's group that kind of used that, and I think dopamine dysregulation syndrome.
I'm
Um,
usually very worried using valproate in Parkinson's because we know that valproate is one of the potential exacerbators of Parkinsonism in the epilepsy population. In fact, is the anti-epileptic most common to induce Parkinsonism. So it's why theoretically might not be that safe to use in Parkinson's. On the other hand, I imagine that there are very few strategies to deal with dopamine dysregulation syndrome. So I'd be very curious to know what the experience has been by Michael Okun and his group in terms of treating dopamine dysregulation syndrome with valproate.
yeah. So moving along, so from monotherapies, onto adjunct therapies, and as you know, just in the past year or two, there has been a big onslaught of a lot of adjunct therapies. We now have Nurians, right? We have, we have the, I guess, Inbrija and then the Kinmobi, the apomorphine strips. So let me start with Nurians, and with which is, for everybody else, estradiol as an add-on therapy. I remember when I was a fellow with Dr. Rao, we were doing clinical trials. Um, we were doing clinical trials with estradiol, and then it took so long before this medication, which was probably approved in Japan long time ago, to be approved in the United States. What degree of confidence do you feel as a movement disorder specialist in a drug? It's like droxidopa, right? It took years and years and years to get approved. What's your degree of confidence in this therapy to provide adequate, on response in patients?
Uh, it's a very good question, and I'm not sure I have the right answer for that. It so why would a therapy take so long to be approved? Certainly, one possibility is that it just is not that good. And yes, that's a very important possibility. But it is not, when we say it's not that good, you have to remember we always set it up in a universe of people that respond very differently to treatments. And one thing that our field has never done, which is a major shortcoming, is to, in every trial, evaluate who responds best to therapies, and just as important, who gets harmed with therapies. In the field of depression, with so many antidepressants, there is pharmacogenomics, the test where you get patients to test, because there are so many, that test that is essentially based on the genomic makeup of an individual would determine or help understand the likelihood about which each of these antidepressants available would be helpful, harmful, or probably futile. We don't have that. We are still using the old trial and error approach, which it's getting old. This is great medicine for the 19th century, but not for the 20th century or the 21st century, much less. So that's one issue, that we are having to test therapies in a universe of people that we don't really know who they are in the biological sense. So that gives me the second way of potentially explaining what you ask without claiming that that's the answer either. And that is that there are likely subtypes of Parkinson's that this therapy is really good for. And I would argue that among the Japanese, this must be a really good therapy, because the studies of istradefylline done in Japan are really helped. They are all positive. They were robustly positive. And it is possible that among the Japanese, there is a type of genetic makeup that renders them particularly vulnerable to benefiting from istradefylline neurons, to the extent that perhaps fewer members of other ethnic groups are. And I'm speculating, but that is one possibility.
I've never really thought of it like that, but that's really is an interesting way of thinking of it, just in thinking
Yeah,
about, um, because when you think about even people having polymorphisms of the COMT, so it's on the similar lines. Um,
exactly.
so let's quickly, people have a lot of questions. So I want to make sure, in terms of the other adjunct therapies that we have. So we have the Inbrija inhaler, and then we have, of course, we talked about Nurians, but we also have, opicapone now, which is a COMT inhibitor, and we have Kinmobi, or the sublingual apomorphine. And if you can just quickly touch on each of those for our patients.
Sure. Well, so Inbrija and Kimobi can be thought of as rescue approaches, meaning that they are going to be inhaled in the case of Inbrija, or sublingual in the case of Kimobi, uh, treatments to bridge a gap, the gap between those cycles where off periods are more often occurring. And they have their shortcomings. I think the main one is that this is not something that can be relied upon for treatment over time. It's really very important to keep them as resources when an on needs to be restored. Uh, Another shortcoming is that when the off periods are in the deepest phase, it's very hard to exit an off state just with either one of these two approaches. It's not impossible, but it's harder, takes longer time. And so it almost is the case that there is some uh, value in thinking whether once you've gotten to be fully off, you're in the bottom part of the off period, whether initiating Inbrija or Kimobi would be helpful. Now, if people that know themselves very well have predictable off periods and they understand when the off period is about to start, then in that situation, you can think of using certain doses of Inbrija or Kimobi at times when the off is about to begin, so that then you kind of abort the deepest part of the off and stay in the on windows as long as possible. Um, so that's I think the approach for to think about this as rescue therapy, which is maybe very important for situations when you are in a social situation or simply any time when an off would be hard to live with because of what's demanded of you.
Yeah, as opposed to, the subcutaneous apomorphine injection, which certainly, would, like you said, it's almost equivalent to efficacy in with levodopa and would possibly turn you on. But unfortunately, comes with, at least in older people, would come with side effects such as dropping their blood pressure, that we call orthostatic hypotension, and then pre-medication also, with Tigan for nausea.
Exactly.
So in light of all of these therapies, would you still think that apomorphine in the right patient would is perhaps a better medication?
Yeah, apomorphine is one of the best medications we have. It is the case that it is not an easy medication because it requires to be titrated to a sweet spot initially that is to be done with a nursing supervisor because of the issues with blood pressure can potentially drop or nausea and vomiting that can appear. Apomorphine was initially used as a drug to induce vomiting in people who were poisoned. And that's why to use it in Parkinson's, it still works as an inductor of vomiting, but then people have to be pre-medicated with Tigan, as you were saying, Dr. Shitness, because they could then they can tolerate the apomorphine's effect on the brain, which is the dopamine stimulation. But once a dose is achieved, if there are no blood pressure drops and people end up tolerating, which is the case for most people, the efficacy is optimal, is as good as levodopa, again, over a very short period of time. But still 90 minutes or so is good enough to bridge those off periods very well. So I think of the three rescue approaches, Inmobi, Imbrigia, and Apokin, which is the subcutaneous apomorphine, the latter is the one that is most effective and very important to consider.
Yes. And then last but not the least, we have two COMT inhibitors. We have talcapone and entacapone, and then we have yet another medication, which is just once a day, and then I mean there are no head-to-head trials, I guess that I know between opicapone and the other COMT inhibitors. What would you say would the role of Ondentis would be in this situation?
Well, so I don't have personal experience yet with it because it's not yet made it to a point where I have patients on that drug, opicapone. Uh, but my colleagues in Europe that have been using it tell me that the experience is very similar to tolcapone, which is far superior than entacapone.
Yeah.
If so, this will be a game changer because tolcapone was one of the best drugs ever developed for Parkinson's, and unfortunately, its use had to decay because there was the potential of liver toxicity, and the need, therefore, to monitor for liver became a hassle, and one that ended up creating problems for this drug to be used on a regular basis. Opicapone does not require liver function testing to monitor for liver disease with this therapy. And therefore, if it works to the extent that tolcapone or any close to what tolcapone did for patients, then this will be very, very effective, far more than entacapone. Entacapone is a rather weak medication. It modestly increased the levodopa duration and therefore the on time. And so the once we learn more about opicapone, it may well be that despite the lack of head-to-head comparisons, that perhaps we will see much more dramatic responses of the type that were seen when tolcapone was in the market.
And so coming to, the people want to know about levodopa formulations. Obviously, we now have Rytary, and if you can just briefly talk about Rytary, and then also briefly talk about the levodopa carbidopa intestinal gel pump or duopa.
Absolutely. So the uh, first of all, I guess the Rytary is a formulation of levodopa that comes in a capsule. It is the longer lasting of all levodopa formulations. It's truly an extended release formulation of levodopa compared to Cinemet CR, controlled release, which was thought to be extended release, and it turns out not to have been. And that's why it's not used on a daily basis. It may still be used for daytime symptoms, or sorry, nighttime symptoms, for sleep related symptom breakthrough, but not for during the daytime. And Rytary, though, has three types of beads within a capsule, and some of the beads are immediate release, some of them are longer lasting release, or immediate, I guess, release. And then what happens is that whereas levodopa creates a peak and then a trough thereafter, with Rytary you get a peak and then a slow decay, because the beats that are going to be active, which are longer lasting beats, they keep the action of the levodopa going on for a longer period of time. So it's a very, very good technology of levodopa delivery. There is actually a Rytary formulation being tested in trials that may in fact extend it a little bit longer, though that's still information we don't know if it will pan out to the extent that is anticipated. What this means, though, is that there is a sense that if we can extend the duration of action of levodopa, we can get to a point where we can have people optimize at the time in which their effect is best. So the one therapy that currently does that essentially is able to reproduce the best response to treatment and keep it as the rule for the day is duopa. That is levodopa carbidopa intestinal gel, and it is a bit of a complicated therapy to use because it requires the placement of a feeding tube, essentially, which is then connected at the other end to a pump that contains a cassette within which there is a bag of levodopa in gel formulation that is titrated, that is essentially tuned to deliver levodopa at a level that keeps people at the sweet spot, so to speak, throughout the day. That is the best of all oral forms not oral, but levodopa forms of replacing what a continuous delivery might look like. Is the best. There is no other therapy that does it quite like it, but is complicated to use. It is not without problems. There are issues very often with the feeding tube kinking in the stomach or in the duodenum. There are pump malfunction. There are issues with the stoma. That's the site through which the pump comes out. And so it's not without problems, but people who are on that therapy, well selected, that's not for everyone, can do incredibly well, right? Very, very well. So it is very, very good, but it's probably so complicated, and there are so many issues with it that the people that can benefit best are relatively a small subset of individuals. Also, it's incredibly expensive. There is nothing more expensive than it. Deep brain stimulation is a fraction of the cost of duopa. So that's why it is. So there are issues related to cost too that have become an obstacle to using it.
Sorry. Do you think the levodopa patch will ever see the light of the day?
The levodopa patch?
Yeah, the Neuroderm.
Yeah, well, I think so. So Neuroderm is a liquid formulation of levodopa that can be delivered through what seems like a patch, because that's kind of, it appears on the skin, but in fact it's a subcutaneous delivery. So the patch has in fact a little needle that goes under the skin into the fat tissue, The other end of the patch is including a little tiny tube that's connected to a syringe. In fact, there are two syringes, so because there are two patches, they can, in a combined system, deliver up to 720 milligrams of levodopa. That's the equivalent orally of about 900 to 950 milligrams of oral levodopa. For people who require less than that per day, this could be really good. The penalty of this therapy is that it will invariably cause nodules and bruises on the skin of the belly. Invariably. It was initially thought that this was going to be a side effect and people can, everybody has it. So therefore, the individuals that could benefit are those who are going to have before it a requirement of levodopa per day that's under 900 milligrams. And despite being under 900 milligrams, of course, they have a lot of fluctuations, quite a bit of off time, and it cannot be bridged with higher doses of levodopa because it can lead to dyskinesia. Those individuals will have no dyskinesia and no off periods throughout the day and would be able to put up with the aesthetic issues, because they are really mostly aesthetic problems with the skin of the belly, with the bruises and the nodules, because they will be so much better. Anybody over the need of 900 or so milligrams a day of levodopa that we have tested with Neuroderm as a system, and this is all within the context of clinical trials, have not done well long-term. Not that they don't benefit, but they don't benefit enough to warrant them to think as a good alternative for them. So it's going to be really good long-term for individuals who have a requirement of levodopa that's under 900. And I think the results have been promising so far. And of course, we are in the midst of the phase 3 trial. And so we will know the results of what this is for another year, probably, if not year and a half.
Yes, thank you. And the last question, that I want to ask is, asked by one of the patient's wife was, my husband has had early onset PD for about 10 years. Dyskinesia has become a bigger problem than tremor for him on a daily basis. Can you talk about medications that are particularly effective for reducing dyskinesias?
Yeah, well, so reducing dyskinesia requires to understand what type of dyskinesia it is. There are two major types of dyskinesia. One is peak dose. That's the most common, about 70% of people. That's when the dyskinesia occurs consistently at the time in which the peak effect of medication is expected. So about an hour, hour and a half or so after each dose of levodopa. Then there is another type of dyskinesia called diphasic. And it's called diphasic because it occurs in both the time when the patients are not yet on, but they're kind of inching toward it, and a time after the on state has happened when they are in fact inching toward an off period. Diphasic, both phases. That dyskinesia can look identical to the peak dose. And the only way to tell the two apart often is to ask patients, when is it that the dyskinesia is worse? Is it worse when the peak effects of medications are otherwise experienced, or is it worse when they are toward the end of a dose cycle and they are kind of anticipating the next dose to happen? If the latter is the case, and they would typically say, well, and once the medication kicks in, that dyskinesia goes away, then we know it's a diphasic. So the reason I'm mentioning these two major types of dyskinesia is because each is treated differently. We typically say dyskinesia as if it were a single animal, and in fact, it's at least two, and each of the two is treated very differently. So the peak dose dyskinesia can be treated either by reducing the dose of medication of levodopa, of course, with the caveat that if you do it, you might end up having reemergence of the Parkinson symptoms, or by adding a medication called amantadine. And there is an extended release formulation of amantadine recently. The diphasic dyskinesia is going to always be improved by increasing the dose of levodopa or reducing reducing the interval between them, or usually both, a combination of both. So you can imagine that it is very important to know what type of dyskinesia we're talking about, because the treatment will vary depending on whether it's peak dose, reducing the dose, or adding amantadine, or diphasic, increasing the dose or increasing the frequency.
Thank you. And I know that when number of medications as antidyskinetic agents in trial, but none of them have really panned out, very well. I mean, even from Sarizotan in early 2000s, and then some of the other ones. And any antidyskinetic agent that you think will be good? Um, in
No, for now, that
Yeah.
cannot. Many molecules have been tried. None of them have really worked out. This reminds me, there is a fantastic video on YouTube. This is an old video now, but I think it's still available, of a person with dyskinesia that tries color lenses. And I think it was blue color lenses. And the minute he would put them on, so he was like this. And the minute he would put it on, completely calm, would take the glasses off and begin to do, and then put the back glasses on, dyskinesia off. And I've always been intrigued by that video. Um, I think that there is some effect of of perceived stress potentially, although it may not be for everyone. So there might be something in that sphere,
Yeah.
implying that maybe some relaxation techniques could help. But the color
Distraction.
is fascinating. It's just a fascinating type of thing. I mean, of course, light of different colors have different effects in the brain, and I'm wondering, that's not to say that if that's the case, that there will be a color for everybody. But I wonder if people who have dyskinesia could go to a store and just try different color lenses and see if there is a color that could bring on relief. I mean, it's
Yeah,
a it's a
I do.
simple approach that could work. I'm not making any claims here, though. Nor do I have any stocks in the sunglasses industry.
We'll have to check on that, Dr. Espay.
All right.
But there's a number of questions. I think these have been answered. Somebody wanted to know about, I've been on Ropinirole for 2 years, seems like not to be effective. And obviously, what would you recommend as a replacement that has minimum side effects? And I think the
Which one?
answer is levodopa, right?
Levodopa, yeah.
Um, and then somebody asked, what is the difference between Cinemet and Rytary? And I think you answered that as well. Let me just go into the Q&A box here. So somebody wanted to know, please talk about apomorphine. When is it prescribed and why? I think that was also answered. Is Rytary the best drug for PD at this time? That's a good question.
Well, Rytary is the best theoretical drug for everyone because it is extended the duration of levodopa. Now, having said that, there is about a 15% of individuals that this stuff doesn't work on. Don't know why. Don't know why, because if we think of levodopa, why should there be any resistance to it? And it's an interesting thing. And it's not that the dosage is inappropriate, is that there is something to it. Now, the major reason people switch over to Rytary may not work. The major reason is because the dosage isn't good. The dose conversion is faulty. It's based on a formula that may apply to an average person, but who is an average person? So when somebody switches to Rytary, if problems occur, the most likely explanation is that there would be a problem with the conversion and that there are adjustments need to be made within a week to kind of help with that. But again, there are those individuals that despite adjustments, nothing work. And so I know that it's not for everyone, even though theoretical is the best for all.
Yeah. And of course, there is a cost of therapy, obviously, with Rytary, if your insurance may not pay for it, right?
Mm-hmm.
Quite possible. Perspective on CBD and medical marijuana.
I have no perspective. I don't know what the mechanism of action will be to help people, but everybody's different. If there is a possibility for people to try it, I'm never opposed to it, but I don't understand how it could work. I think that in my experience, some people have said, well, they like it and they feel better. Some people have said they don't feel anything with it. And some people said it makes them worse. So it's kind of the experiences all over the place. I think it's one of those situations where we don't have enough data to know how it could work for most people. And certainly, like all therapies, it may just be that there could be a few that could benefit. Don't know who they might be, what kind of features somebody that would benefit from this therapy would have to have, nor we don't know who might, in fact, use this to no avail. We just don't have data.
Yep. Do you have any favorite herbal supplement, Dr. Espay?
No, I'm particularly skeptical to supplements, and here's why. When I was in training in Toronto, we have our DBS program included in taking patients. So DBS program is for people who, of course, haven't done as well as we would want them to be with normal treatments, and we think that deep brain stimulation, surgical intervention could be the approach for them. And part of the protocol required for us to take people entirely off their herbal medications, all of them. And that was just part of, we wanted to see what they looked like without. And there was a group of people that did so well after they were removed from herbal therapies that they no longer were qualifying for deep brain stimulation. They were that much better. They did not qualify for deep brain stimulation. So ever since that experience from the protocol happened, I realized that I don't know who might benefit to a great extent with herbal medications, but I certainly know that there is a group of individuals for whom herbal therapies may in fact be harmful, and they don't know it. They think it's a disease, they think it's progression, they think it's some other medications, but they cannot think that it could be the herbal because the herbals can only be good. And it may not be the case for everyone.
Absolutely. Can you please speak to the impact of these medications on cognitive function, benefits versus side effects?
Well, the medications side effects in terms of cognition, I would mention a little bit about dopamine agonists. In general, when somebody has cognitive difficulties, I'm always looking through the list of medications, the things to try to move out of for people who have cognitive impairment or hallucinations. Hallucinations are some indication of an underlying cognitive vulnerability. The things to worry about are drugs with anticholinergic properties. In Parkinson's, we think of benztropine, that's cogentin, or trihexyphenidyl, that's Artane. But for instance, bladder medications such as Flomax can affect cognition. So unless there is a really important reason for Flomax or other bladder medications to be there, we try to remove those out of the system. Amantadine, we mentioned how good it is for dyskinesia, but if anybody has cognitive difficulties, that's one medication we like to eliminate because it can contribute to cognitive impairment. And in fact, people who may have hallucinations, when we discontinue amantadine, hallucinations disappear. So it's a very important medication to ensure that you don't have when you have these problems. Then down the list is dopamine agonists. We talked about that they could have detrimental cognitive effects, and then MAO-B inhibitors. Levodopa, well, it could have some issues cognitively in some people. It's so important that is the medication we never get rid of. It's very important. It's the one medication nobody can do without. But these other medications are kind of important for us to remember to remove. One general principle here is that as we age with Parkinson's, therapies that may have helped people early on come to a point where they may no longer help, and in fact, they may be harmful. That is, the window closes in terms of when they are beneficial. Amantadine, for example, is one of them. So we need to always be mindful that as we age with Parkinson's, we want to have fewer medications on board. We don't want to have too long a list of medications. We want to start cleaning up and leaving ourselves with just levodopa. Levodopa is the one medication we shouldn't do without, but if there is a whole bunch of other medications and different problems, we like to clean out the regimen as much as possible and leave only levodopa if at all possible. Many times when we do this, we accomplish a lot of goodness. People feel better just because they're removing themselves from medications that may have worked at some point, but no longer are doing so. And in fact, are now at the point in which we're considering a simplification of the medication regimen more trouble than they are worth.
And interestingly enough, once people have undergone DBS, I tend to do the same. I tend to clean them out pretty much of most everything else, perhaps leave them on Rosagilin and some form of levodopa carbidopa. That's it, and DBS. And, then it works well pretty much for the rest of their life. This is an interesting question. I know we are running out of time, already run out, but I wanted to ask this. Um, I've had Parkinson's for over 30 years and do not take any medication. I'm wondering if taking dopamine would be beneficial after all these years.
If it's never taken a medication, never develop has never been part of the picture.
That's what they say.
No,
I don't know
I mean, here's what I would say. I would like to see you in clinic. I would like to examine you and understand if you have Parkinson's. It could be that what has been interpreted as being Parkinson's may not be, which would be a good thing, of course, because sometimes there is something else that requires completely different treatment, or it could be that, there's a variety of explanations for that. It's very unusual, but Parkinson's does come in many flavors, so it is possible, but it will be unusual for me to think that that's the case, and levodopa has never been needed.
And interestingly enough, as we know, before 1967 and the advent of levodopa carbidopa, the lifespan of people with idiopathic Parkinson's disease was not even 5, 6, 7 years, because they got stiff and rigid and bed bound. So that's why what you're saying about, is this diagnosis truly Parkinson's, or is there a very slowly progressive phenotype of Parkinson's disease that a person may have particularly. I have one question for you. Why does Inbrija not come with carbidopa? Is that just a formulation thing?
Yes, it is a formulation thing. It could not be, I don't think it could be part of it in the molecule. It couldn't be deliverable
in that form.
in that form.
Yeah.
Exactly. Be mindful that there will never be a cure for Parkinson's. That's not to say there will not be a cure for each of you, but there will not be a cure for the disease, because there is no disease. It's people with the disease. We've created a great construct about what Parkinson's is, but in fact, each individual has a different disease that happens to have as a common element slowness, rigidity, tremor, etc., with a variety of different expressions. Nothing will work. There is a big deal of predatory businesses out there that will claim that this one thing is going to be the thing that's going to cure it. And NADH doesn't pass the smell test. It is very similar to glutathione. It's very similar to creatine. It's very similar. We have a long history of fascinating molecules that might work for some people, but we don't know who they are going to work for. So don't let yourself be fooled into getting on a treatment just because it sounds exciting, just because it seems like it's going to be a free radical scavenger, just because it seems like it's going to be something marvelous. There might be reasons that they could be beneficial. Somebody mentioned omega-3 fatty acid. Yeah, it could be helpful for the heart. We don't have evidence that it could help Parkinson's specific to each individual. In the future, we might be able to tell whether some of this will help individuals with certain types of Parkinson's, but we don't know who they are yet. In Cincinnati, we have a program where we're beginning to understand individuals at a deeper biological level. It's called CCBP. Website is ccbpstudy.com. CCBP stands for Cincinnati Cohort Biomarker Program. And it is the first study where we're really looking at matching people to therapies that already exist. Because we think that all of these therapies that have been developed that have always invariably proven to be negative in trials, it's not that these molecules are futile, it's that we've never known who they are for. And the program we have in Cincinnati is precisely to find matches to those therapies, people that would in fact stand to benefit from them. But until then, we don't know who they are. So thank you, Arthur, for that important question.
And with that, thank you so much, Dr. Espay. Always a pleasure. And thanks for the great information. I think we have this evening managed to clear at least quite a few myths about, initiation and and gene therapies for Parkinson's disease. So thank you so much.
Thank you, Shilpa.
Thank you, Dr. Espay. Such great information. Thank you, Dr. Chitnis, for moderating. Thank you all for joining. I know we weren't able to answer every single question. We got a ton of questions from you guys, but thank you for joining tonight and thank you for participating. And I hope you found this information helpful. If you are new to SkyPass Foundation and these Ask the Doctor series, please send us an email at info@skypassfoundation.org, and we would be happy to send you more information about other webinars that we do similar to this one. So with that, we'll wrap it up. Thank you again, Drs. Espay and Chitnis. Have a great night, everyone.